Okay, so does everybody see my screen? Can someone just confirm that my screen is indeed being shared? Okay, so I'm going to assume that everybody can see my screen and that the camera is working. And with that, let's get started. So, Assalamu alaikum, everybody. My name is Abdulrahman Aldahash. I'm a third year medical student. And today we'll be going over the mechanics of the heart. Now, this includes three of your lectures, which will be the cardiac cycle, the pressure volume loops, and heart valves and sounds. Now, they contain a lot of content. So, I've done my best to simplify everything as much as possible while also making sure to include everything that is going to be high yield, likely to come up in your exams, so on and so forth. So, with that said, Bismillah, let's get started. So now a question to the people in attendance. What is the main function of the heart? If somebody could just unmute their mic and answer, please.
Can you hear me?
I can hear you, yes.
Yeah, to pump blood throughout the body and to circulate blood flow.
All right, fantastic. Thank you very much, Fahad. So you're correct. The main function of the heart is to move blood throughout the body. But how does it do that is what we will be talking about today. So, first of all, what is very important for you guys to keep in mind is that the anatomy of the heart is very much related to its physiology, especially when we start talking about things like pressure. So, let's do a very brief overview of the anatomy. So, first things first, how does the blood flow through the heart? Now, again, like your colleague Fahad said, the function of the heart is to move blood throughout the body, pumping it first to the lungs to get oxygenated, and then to the body so that the organs can use the oxygenated blood. Now, the organs, with their use, deoxygenate the blood, and that is where we have the blue bit, which is going to be the oxygen poor blood flowing into the right side of the heart, out into the lungs, back into the left side of the heart, and then out into the circulation. So the first thing that we have here is the right atrium. This is going to be the first thing that deoxygenated blood enters into, and then afterwards it travels through the tricuspid valve into the right ventricle. Now remember, we have two atria and two ventricles, and we split the heart into two pieces, the right and the left heart. So after traveling through the tricuspid valve, it's going to go into the right ventricle, which will then contract and send the deoxygenated blood into the lungs through the pulmonary arteries. Now, do not get confused. Even though they're called arteries, they have deoxygenated blood. We call them arteries because they're sending blood away from the heart and not towards. After the blood is oxygenated in the lungs, it's going to travel through the pulmonary trunk and into the left atrium. Now, the left atrium is going to pump blood through the mitral valve into the left ventricle. Now, the left ventricle is the biggest and most muscular part of the heart. So it's going to be responsible for pumping blood into the massive vessel here, which is what we call the aorta. Now, for the blood to travel from the left ventricle into the aorta, it has to pass through the aortic valve. And you can see everything labeled down here. And now, this is again just a further simplification. We'll have deoxygenated blood traveling through the right atrium into the right ventricle through the tricuspid valve, and then into the pulmonary arteries through the pulmonary valve, back into the heart, into the left atrium, because it's now oxygenated, through the mitral valve, into the left ventricle, and then into the aorta through the aortic valve. Is that clear to everybody? I'm going to assume that it's clear. So let's talk a little bit about the valves. If we open up the heart to look at the right side, here we see this, the right atrium, and this is what we call the tricuspid valve. Now, the valves function to keep blood from going in the opposite direction. So the valve between the right atrium and the right ventricle is going to be called the tricuspid valve. And then the right ventricle contracts into the pulmonary artery, and here we see the pulmonary valve. If we open up the left heart, we can also see a very similar structure. Here we have the left atrium, and then the blood is going to travel inside into the left ventricle through the mitral valve. And if we look at the heart from up top, here we can see the tricuspid valve of the right atrium and the mitral valve of the left atrium. And then here we have the aortic valve from the left ventricle into the aorta, and here the pulmonary valve from the right ventricle into the pulmonary artery. Now here is an echocardiogram or an ultrasound of an actual beating heart. Now, as you can see, the heart goes into, it contracts and then it relaxes. And this is what we call systole versus diastole. Systole is the contraction of the ventricles, which are, as we said, these big parts of the heart to pump the blood out of it. And diastole is going to be contraction of the atria, or the smaller parts in the top, to pump blood into the heart. So during systole and diastole, the valves are going to change depending. So the tricuspid and the mitral valves open with atrial contraction, or what we call diastole. So again, when the tricuspid and mitral valves open, it means that we have diastole, or filling of the ventricles. Now let's compare that with systole, where the bigger chambers of the heart are going to squeeze and send blood out of the heart. Here we have the opening of the pulmonary and aortic valves. Is that clear to everybody? I hope it is. So as you can see here, wonderful. So as you can see here, during systole, the tricuspid and mitral valves are going to close. This is because we want to prevent backflow of blood into the vessels, and we want it to go into these big vessels and out to the rest of the body. That is why we have the valves in the first place. So this is a very quick summary of the anatomy. We have 4 chambers, 2 atria, and 2 ventricles. The atria will move blood from the vessels into the heart inwards, and the ventricles move blood from the heart to the vessels outwards. The right ventricle pumps into the pulmonary arteries deoxygenated blood into the lungs, and then the left ventricle will pump oxygenated blood into the aorta out to the rest of the body. Now, again, we said that we have 2 different types of valves. We have 4 valves in total and 2 different types. We have the atrial valves, so the ones in the atria, between the atria and the ventricles, which are the tricuspid for the right heart and the mitral for the left heart. And then we have the ventricular valves, which are going to be the aortic and pulmonary. Now, a nice way to remember these is that the mitral and tricuspid valve are named on how they look, whereas the aortic and pulmonary valves are named on where they lead. So if we go here, this is the tricuspid valve. It has 3 flaps, so that is why we call it a tricuspid. The mitral looks like a hat that some people wear. You can look it up, a mitral hat. And then here we have the pulmonary valve, which leads into the pulmonary artery, and the aortic valve, which leads into the aortic artery. I hope that's clear to everybody. Now, again, we said that diastole is going to be the filling of the ventricles through pumping of the atria, and systole is going to be emptying of the ventricles through the contraction of the ventricles. Okay? So when the atria contract, we fill the ventricles. When the ventricles contract, we empty the heart. Okay. So as you can see, the volume inside the ventricle is going to change from systole to diastole. Here we have diastole, where we fill the ventricles, we see that they expand, as opposed to systole, where we contract or crush the ventricles. So we see that blood escapes out of the heart and we reduce the amount of volume within. So we introduced 2 concepts, an end diastolic volume and an end systolic volume. what is end diastolic volume? It is going to be the volume of blood in the ventricle after diastole is completed. Now, again, we said diastole is relaxation of the ventricles, so it will be filled, a filled ventricle, as opposed to the end systolic volume, which will be the volume in the ventricle after systole, or after we contract or crush the ventricles. Okay? Now, how much does the heart move in one beat or cycle? So again, we said in diastole we fill, and then in systole we push out. That is one beat of the heart. So how do we find out how much blood it's actually moving? It's very simple. We say that we measure the stroke volume by doing EDV minus ESV. So the end diastolic volume is how much we put into the heart, and the end systolic volume is how much we poured out. So to figure out how much you moved, you're going to subtract the number that you ended up with from the one that you started with. It's like this glass right here. Do you guys see my camera? Okay, I don't know if you guys see my camera, but it's like having a filled cup and
We can't see your camera.
okay, that's fine. So it's like having a filled cup, which you then pour water out of. To measure how much water you poured, you measure the amount that you started with, which is the end diastolic, minus the amount that you ended up with, which is the end systolic volume. And that is what we call the stroke volume, or the volume moved in one stroke of the heart. Now let's go through some basic terminology and set some ground rules. So again, end diastolic volume is the volume in the ventricle after diastole, and systolic volume is the volume of blood in the ventricle after systole. Stroke volume is EDV minus ESV. That is how much blood we moved in one pump of the heart. And we use that measurement to determine what we call cardiac output. So this is how much total blood that the heart is putting out through a period of time, usually in 1 minute. So we do stroke volume times heart rate. So heart rate is how many times the heart will pump, i.e. go into both diastole and systole in 1 minute, times the stroke volume. So again, this is a repetitive process. And over a period of time, you're going to be moving a certain amount of stroke volume every time, and you multiply that by the times that you actually contracted, or every stroke of the heart. And we can also use stroke volume to measure something else, which is what we call the ejection fraction. Now, the ejection fraction is how much percentage of the blood in the heart did we move. This is a very important clinical measurement. And the normal amount of blood that is pushed out of the heart is usually 55 to 70% of what we started out with. I hope this makes sense. So again, end diastolic volume is going to be the total blood in the ventricle after diastole, the maximum amount after we fill the heart. If we find out how much we moved, how much we pushed out, the stroke volume, and divide that by the total that we started with, we get the ejection fraction. So the percentage of blood that is being moved by the heart. And as you can see here in this other echocardiogram, that the heart is filled with blood, but it doesn't push all of it out when it contracts. You can see the ventricles contracting here. So a portion of blood remains normally, and a healthy person will have an ejection fraction, or will eject 55 to 70% of the blood inside the ventricles. Is that clear to everybody? Okay.
Clear.
Fantastic. Thank you very much. So I hope this concept is clear. Now, let's talk a little more about basic terminology. We have systolic blood pressure. So again, we said that during systole, the blood is being pushed out. So if we measure the pressure exerted against the arterial walls during systole, we get something called the systolic blood pressure. Compare that to the diastolic blood pressure, which is the pressure during diastole, or ventricular relaxation / atrial contraction. Because remember, we said that when the ventricles relax, the atria contract, and vice versa. Now, if we subtract systolic blood pressure minus diastolic blood pressure, we get something called the pulse pressure. Now, this is not very important for you at this stage, but I've just mentioned it for the sake of completion. Now, I'm sure all of you have been to the hospital and seen this. This is a vital monitor, and this part here specifically is the person's blood pressure. So this big number is the systolic blood pressure, and the small number is the diastolic blood pressure. So it's very natural that the systolic blood pressure will be higher than the diastolic because the atria contract very strongly. They push out a large amount of blood, as you can see. Hold on. Yeah. So the left ventricle has to get blood throughout the entire body, not just a single portion. So the force of contraction is going to be very large, and that is why the systolic blood pressure is very high compared to the diastolic. Now let's go back here. Okay. So is this clear to everybody? I'm assuming it is. Now, let's do a question together. A patient presents to the ER complaining of severe chest pain radiating to the jaw and left arm, diaphoresis or sweating, and a sense of impending doom. This patient's end diastolic volume is measured at 120 milliliters, and her end systolic volume is measured at 80 milliliters. What is this patient's ejection fraction? Does anybody want to solve? Okay, so I'm assuming that some people are solving. I'll give a few minutes or a few moments for you guys to try and solve.
They're answering in the comments in the chat.
Okay, let me open the chat. And let's see. Okay, I'm seeing A, C, and B. So you're correct, actually. The right answer is going to be A. Now, why is that? We said that the ejection fraction is going to be the percentage of blood that we push out of the ventricle from the total amount. So what we do here, now what we need to find the ejection fraction is we divide stroke volume by end diastolic volume. And so to find the stroke volume, we have to subtract the EDV from the ESV. And that is why this is kind of a tricky question. So she started out with 120 milliliters at the end of diastole, and then at the end of systole, so after contraction, she remained with 80 milliliters. So 120 minus 80 is going to be 40 milliliters. That is the amount of blood that she pushed out, and that is the stroke volume. So once we divide the stroke volume, which was 40, by 120 milliliters, we get 33%, which is the ejection fraction of the patient. Is that clear to everybody? Okay, wonderful. Fantastic. That's great to hear. Now let's do another question. Oh, first we're going to talk about cardiac output, and then we're going to do more questions. So cardiac output, we mentioned that cardiac output is equal to the stroke volume times the heart rate. It's a very important clinical measurement because it tells us how hard the heart is actually working over time. Because this is, it's a way of basically, how do I say this? Measuring the sum total of the heart's work throughout a period of time. Now, how can we change cardiac output? We can change these two parameters. So if we increase or change stroke volume or heart rate in any way, we're going to increase or decrease the cardiac output accordingly. So how do we change the stroke volume? Does anybody have any guesses? I'll open the chat. Does anybody have any guesses as to how we can change the stroke volume? Come on, guys. I want answers. Yeah. Increase venous return. More contractility. Okay, mashallah, you guys are on top of it. Increase the preload or end diastolic volume. Okay, fantastic, fantastic, mashallah. So you guys are correct. Increasing venous return is going to increase the amount of blood that we put into the ventricle, which is going to increase what? It's going to increase the end diastolic volume, meaning that we're increasing the total blood that we can even pump out. So now some of you guys already jumped ahead, but the parameters that we use to change stroke volume are preload, afterload, and contractility. Now, increasing the end diastolic volume increases preload, and we're going to talk more about this in a minute. The afterload is going to reduce stroke volume. We'll also discuss that in detail, and then we can increase the contractility. Now, contractility is basically how hard does the heart contract, or how strong is one pump of the heart. And we can also increase the heart rate. So this is increase or decrease, and that's going to be very straightforward. So let's talk about these parameters, the preload, afterload, and contractility. Before we do that, you guys remember the myocytes of the heart, or the muscle cells. So here we have the thick filament, and here we have the thin filament, myosin and actin. You guys already covered this in your foundation block, so this is going to be a very quick review. But basically, when the thick and thin filaments overlap at a certain point, you're going to recruit the highest number of myosin chains. So ideally, when the actin and myosin overlap at this level, you're going to have the strongest level of contraction. If there's not enough stretch of the actin filament, you are not going to be using all of the myosin, so you'll get a weaker contraction. And oppositely, if you have too much stretch and the actin is very far away from the myosin, you'll have a very weak contraction because you're not really using all of the myosin filaments. And if you stretch far enough, you're not going to have any contraction at all. And this is how it looks like on a graph. Now, if we stretch at a certain point, we get this ideal or golden range, or the normal range of sarcomere, which coincides with B. Okay. For the point that I want to get to you guys is that the more we stretch the muscle, the higher the contraction, or the stronger the tension is going to be. Okay. So let's talk about preload and afterload. How does that relate to preload? So preload, we can think of it very simply as the amount of blood loaded into the left ventricle before contraction. And it's in the name, preload, right? We're going to put more load at the start or before we contract. Now, more blood is going to lead to more stretch of the myocytes here. So again, imagine the heart with me. If you fill it with blood, it's going to stretch out, and that's going to increase the stretch of the heart. And what that does is it creates a net stronger contraction. Why is that? Because again, here, we're going to have better recruitment of the myocytes. So that leads to a higher stroke volume, leading to more cardiac output. If we go back here, cardiac output, if we increase the stroke volume by increasing the preload, we increase the cardiac output. And again, this is the picture right here for your, just to keep it in mind. And let's talk about afterload. Afterload, also in the name, it's the load after contraction. So these are the forces resisting blood flow out of the left ventricle. More resistance is going to equal less blood pushed out. And that should make sense to you, that any forces opposing pushing blood outside of the heart will naturally lead to less blood flow. So this leads to a lower stroke volume and a lower total cardiac output. And again, here, for example, the aortic valve, sometimes we have a pathology called aortic valve stenosis. Now, if the aortic valve is not opening enough, we're not going to have a strong enough contraction of the left ventricle to push the blood out. And this is increased afterload. Is this concept clear to anybody or to everybody? I want some answers in the chat. Okay. So Newell says it's clear. Is anybody, finding any difficulty understanding these concepts? Okay, wonderful. So it looks like everybody agrees that the concepts are clear. So now let's talk about how we can modify preload and afterload. How do we change preload? So anything that increases the amount of blood prior to contraction is going to equal more preload and more cardiac output. So a higher volume of blood, like increased venous return, for example, will equal more blood into the ventricle and more stretch of the myocytes. Another thing that we can do is slow the heart rate. Now, like we said, we have both systole and diastole. The heart is filled during diastole. So if we slow down and increase the length of diastole, we're going to increase the time that is available for blood to flow into the ventricle, which also kind of leads to a higher volume of blood. And what we can do in addition to all of these is do venous constriction. So how we can explain this very simply is that the veins are the biggest store of blood in the body. You have a lot of veins in your legs, you have a lot of veins in your abdomen that store blood that isn't moving very much. So if we constrict these veins, we're going to push the blood out of the veins and into the heart, which increases the volume of blood. So the theme here is that to increase preload, you need to increase the amount of blood going into the left ventricle. Now, additionally, or naturally, anything that decreases the amount of blood prior to contraction is going to equal less preload. This should make sense to you. It's the opposite mechanism here. There is less stretch of the myocytes because there's less blood, so we'll get a slower or a weaker contraction or weaker stroke volume. So less volume, as in hemorrhage, faster heart rate, less time to fill the ventricles, and venous relaxation, which causes the blood to go back into the veins, will all reduce preload. So let's talk about how we can change afterload. Changes in afterload, again, will be anything opposing the pumping of blood outside of the heart. So that's also going to decrease cardiac output. So increased systolic blood pressure. If the blood pressure inside the big arteries of the body is increased, the heart has to work harder to push the blood outside of it. So that will increase afterload and reduce stroke volume, reduce cardiac output. A stiff aortic valve is going to cause increased afterload because the heart has to pump harder to pop the aortic valve open. And to reduce the afterload, you just do the exact opposite of everything that we mentioned. Is this clear? I'll just assume that it is because I feel like I'm stopping too much. Okay. Now, lowering blood pressure and managing the valve pathology will both decrease afterload, which causes an increase in stroke volume and cardiac output. So this is just a very cute image to help you remember everything. That preload is the volume of blood pumped into the ventricles at the end of diastole, or the EDV, okay? And it's going to increase in anything that increases the left ventricular blood volume. And afterload is the resistance that the left ventricle must overcome to circulate blood or pump it out. So like we said, it's going to be increased blood pressure and stiff aortic valve. Now, remember end diastolic volume and end systolic volume. How do we relate those to preload and afterload? So the EDV, volume of blood post-diastole, ESV, blood after systole, or after we empty the ventricles. The end diastolic volume correlates linearly with preload and cardiac output. What does that mean? So again, imagine that I'm filling the heart with blood. The more I fill the heart with blood, so the greater the end diastolic volume, the greater the preload is going to be, and the more stretch I'll have with the myocytes. Now, on the opposite end of the spectrum, end systolic volume correlates inversely with cardiac output. What does that mean? This one is a little more confusing. So the end systolic volume is the volume of blood after I pump, after I go through systole. So if I have a high ESV, that means I'm not pumping enough blood, right? Because the end systolic volume is the volume after I stroke. If the stroke volume is high, the ESV will be low. That means that is high cardiac output. But if the ESV is high, that means it didn't change much from the filling to the constriction. So that means that a high ESV means I have a lower cardiac output. And just a point here that ESV will be positively correlated with afterload. Because if I am pumping less blood out of the heart, that means the afterload is high. There's something stopping the blood from leaving the heart. Is this concept clear to everybody? I'm going to open the chat. Okay, somebody's saying lower preload leads to lower heart rate, or the opposite? No. So it's a good question. Lower preload, let's go back here. Sorry. It's actually the heart rate that affects the preload and not the other way around. So if I have a low heart rate, that means that there is more time for blood to go into the heart, which increases. So low heart rate equals high preload, and high heart rate equals low preload. Is that clear? All right, fantastic. Okay. So one last slide about values. The left ventricular end diastolic volume is going to be looking at the EDV of the left ventricle, LV specifically. And in addition to that, the left ventricular end diastolic pressure is the measured pressure in the left ventricle at the end of diastole. Okay? So this is a summary of everything that we talked about. I'm going to go through it very quickly. We have the end diastolic volume, which is the volume of blood in the ventricle after diastole. The end systolic volume of blood after systole. We have the stroke volume, which is EDV minus ESV, how much we started with, how much we ended up with. And then we can use that to measure cardiac output, which is the total output of the heart, how much work is the heart doing, multiplying stroke volume by heart rate. And we have the ejection fraction, which is the percentage of blood that we are pushing out of the heart. Again, we said normally it's going to be around 60%. And to measure it, we do stroke volume divided by end diastolic volume. Okay? Now we have the systolic, diastolic blood pressures, and the result of subtracting those from each other will be the pulse pressure. How can we change the stroke volume? We can change preload, afterload, and contractility. Preload is going to be by increasing stretch of the heart. Afterload will be increasing the pressure against the left ventricle. Now, I highlighted preload in green to help you remember that increasing preload increases the stroke volume. Increasing afterload, or making it harder for blood to leave, will decrease the stroke volume. Okay? Does anybody have any question about all these numbers and equations that we talked about? All right. Okay, fantastic. Everything is clear. Wonderful. So now let's do a few questions about everything that we just discussed. Let's read the question together. Does anybody want to read the question?
Can I?
Yeah, go ahead.
An 89-year-old woman presents to the emergency room with complaining of substernal chest pain, which she describes as dull and pressure-like. The on-call cardiologist orders a Doppler echocardiogram, upon which the patient's ejection fraction is calculated at 35%. Which of the following values is most likely to be elevated in this patient?
Okay. So can you tell me your name, please?
Majd.
Okay, Majd. So now the question here says that the ejection fraction is 35%. Is that a high or a low ejection fraction?
Normally the stroke volume is 70 out of 120. I don't know what that is in percentages.
Okay, so to help you remember, the ejection fraction should be 55 to 70% of the, that's the normal
So it's low.
Okay, yeah, so this is a reduced ejection fraction. Okay, so that means that the heart is pumping less. So which of these is going to be elevated in this patient?
The afterload,
The
which
afterload.
decreases the stroke volume.
which decreases the stroke volume. Fantastic, mashallah. Okay, mashallah, wonderful, wonderful answer. Why is it not preload?
Increased preload would increase the stroke volume, not decrease it.
Exactly, fantastic. And all the other answer choices are going to be very wrong because they don't have much to do with the end result of the ejection fraction. So, thank you very much. A second question. Does anybody else want to read?
Sure. A pregnant woman arrives to your clinic for scheduled perinatal follow-up. All vitals are normal, but upon measuring her left ventricular and diastolic volume, a marked elevation is noted. Though the patient is asymptomatic, which of the following parameters is increased, and what is the underlying mechanism?
Okay, so it's saying here that the left ventricular and diastolic volume is increased. So which of these, when increased, will increase the left ventricular and diastolic volume, and what is the cause of that increase? This one is a bit tricky, so take your time with the question.
Is it B?
B, stroke volume and increased heart rate. Okay, can you tell me why you think it's B?
Because the left ventricular and diastolic volume is increased, and so the cardiac muscle will stretch, and if it
Okay,
stretches, it contracts even more, which increases stroke volume.
okay, you're absolutely correct on this. However, does increased heart rate increase the stroke volume or reduce
No,
it?
no, reduce
It
it.
doesn't, right?
Yeah.
So this, you're very correct about the stroke volume, okay? But the correct answer is actually preload and increased blood volume. Now, I put this question because physiology questions can be very tricky like that. And this is how they're going to look on the exam sometimes, where one part of it is correct, but the reason why is wrong. So you're going to have to read through the options carefully. So can you explain why it's C?
Because preload, more blood, and it stretches the same thing. Same like more blood goes into the heart, which
Okay,
causes a stretch.
okay,
The stretch will increase contraction, and
okay.
so it increases the blood volume.
All right, fantastic. You're absolutely correct. Um, thank you guys very much. We're gonna take a short 5 to 10 minute break, and then we'll. All right. So what we're gonna do is we'll finish the bulk of our session right now. We'll take another short break, and then we'll finish the last part of the session. We'll do some quick questions together, and afterwards, I'll leave you be. So now it's time to apply everything that we have just talked about. So where is the summary slide? I'm sorry, guys. Okay. Here. So just remember EDV, ESV, stroke volume, cardiac output, ejection fraction. These are all very important ideas. Now we're going to be correlating them with all the graphs and things that you see in the lectures. So let's get a functional example of preload. So again, like we said, preload is going to be stretch of the myocytes. Here is the stroke work output curve. Now, Dr. Modi put this in the slides. So for the sake of completion, we'll be going over it. Here we have the stroke work on the y-axis, or how much blood we're pumping out on the y-axis. And then the volume is going to be in the x-axis. Wait, I think I got that wrong. The stroke work, i.e. the strength of contraction, and then the volume is going to be across the x-axis. So here, basically, we're saying that the more we stretch the ventricle, the more blood and pressure is going to be produced. And we see it both in the left ventricle and in the right ventricle. Now, the biggest difference between these two measurements is that the left ventricle is going to produce a much higher, it's a much stronger contraction and a much higher pressure. And it's also going to be pushing more blood out as opposed to the right ventricle. And again, this is a functional example of the myocyte stretch. Now, another example of preload is going to be the ventricular volume output curve. Again, here we see that the higher the atrial pressure is, so the more blood we pump into the ventricles through the atria, the higher that the ventricular output is going to be. So atrial pressure, i.e. the pressure caused by the contraction of the atria filling the ventricles, is going to increase the amount of blood, increasing the preload, and increasing the output and the stroke volume of the ventricles. Again, I know I'm repeating myself here, but it's a very important basic concept. So this is what we call the Frank-Starling relationship, which is the stretch of the myocytes. This is just the fancy name for it. Now let's talk about afterload. So like we mentioned, one of the things that is going to increase afterload and make it harder for the heart to push blood out of it is going to be the arterial pressure or the systolic blood pressure. So the heart, up to a certain point, can maintain good cardiac output even when the arterial pressure is high. But once it gets incredibly high, at around 200 millimeters mercury, we see a dip in the efficacy of the heart pumping the blood out. So again, here the arterial pressure is the x-axis and the cardiac output is the y-axis. A higher afterload lowers the cardiac output. And this is just the image to remind you once again of the relationship. Now, we're going to talk very briefly about valves. We talked about the preload, afterload, but how do the valves play into everything that we have discussed today? So again, these are going to be the atrioventricular valves, the valves between the atria and the ventricles. In the right heart, we have the tricuspid valve, and in the left heart, we have the mitral valve. And we can see them here. In diastole, during atrial contraction, the atrioventricular valves, the tricuspid and the mitral, will be open because the blood is going inwards through here, and the ventricular valves will be closed. During systole, the pressure produced by the ventricles is going to push the pulmonary and aortic valves open to push the blood out. So again, this confused me very much when I was in first year. So it's very important that you remember which valve is where. The atrial valves are the mitral and tricuspid. We also call them the atrioventricular valves because they're between the two. They're named by how they look. And the ventricular valves, the aortic and the pulmonary, are named on the vessels that they lead to. The ventricular valves are going to be between the ventricle and the vessel. The atrial valves are between the atria and the ventricle. So which valves open with systole or ventricular contraction to allow the blood out? They're going to be the aortic and the pulmonary. The way I remember it is that, we're pushing blood through these valves, through these arteries, so they're going to be the ones named after the arteries. Now, which valves open with diastole? They're going to be the mitral and the tricuspid valve, which is during the relaxation of the ventricles. But how do these valves open in the first place? Does anybody know how the valves actually open? Do they open on their own or what? I'm going to take answers. Okay, pressure, exactly. And yes, you are correct. We also call them the semilunar valves. You guys are doing fantastic. When I was in first year, I'm going to be very real with you. I did not understand that concept until very late into the block. So you guys are doing very good. So you're correct. By increasing the pressure, the valves get pushed open. So as you can see here, the pressure from the atria is going to open the atrioventricular valves because they open this way, and then the pulmonary and aortic valves will be pushed open by the pressure produced by the ventricles. The only way that the valves open and close is through an increase in pressure, okay? And this is a very fancy animation that I found online. Here you can see that the valve is getting pushed open by a very high and strong jet of blood flow through the vessel, and that's just to help you remember that you need a lot of pressure to open the valve. So the left ventricle must generate enough pressure to open the aortic valve, and the right ventricle must produce enough pressure to open the pulmonary valve, okay? Now, functionally, the valves act as afterload. Why is that? Because they are barriers against the movement of blood outside of the chamber, okay? And this is going to be very important once we talk about pressure volume loops later. So, you know, the heartbeats, the ones that we hear by the stethoscope, they're caused by the closing of the valves, not by the opening. This one is very important. The heartbeat that we can feel and hear is caused by the forceful closure of the valves. As you can see here, they kind of slap each other shut. So they produce vibrations, which we can then auscultate with a stethoscope, okay? So we have two heart sounds that are natural and normal in the human. We have the S1 and S2 heart sound, which they call lub and dub. I'm going to be very honest with you. I am now in my third year of medicine, and I've never been able to hear the lub or the dub. I just remembered that it's S1 and S2, but if they ever ask you which one is lub, which one is dub, you know, this should help you remember. So the S1 heart sound is produced by closure of the tricuspid and mitral valves, okay, by closing the atrioventricular valves, and the S2 heart sound is by the closure of the pulmonary and aortic valve. Let's talk about that again. So the normal sounds are going to be S1, caused by the closure of the mitral and tricuspid. Does anybody know what stage of the cardiac cycle this is? So when the mitral and tricuspid valves open, is this systole, diastole? What is it? The beginning of systole is S1. Diastole ventricular relaxation. Diastole, systole, isovolumetric relaxation. Okay, so I'm getting a lot of answers. And all of you guys are correct in some way, but you have to be very specific when specifying when S1 and S2 starts. So once we close the mitral and tricuspid valve, this coincides with the end of diastole and the beginning of systole, okay? Now, I think somebody wrote this in the chat, so props to you. But the end of diastole is when we close the valves that lead from the atria to the ventricles. So we have finished the filling stage and we have started the shooting or the pumping stage, okay? So this coincides with the end of atrial contraction or ventricular relaxation. Now, S2 is going to be closure of the atrial and pulmonary valves or the ventricular valves. This is going to be the other end of the spectrum. It's going to be the end of systole, beginning of diastole. So we have pumped the blood out and the atrial and pulmonary valves are going to close because khalas, we finished this stage. You're going to hear a very loud sound. S2 is usually louder than S1. And that means that the ventricle khalas, it pumped the blood and it's relaxing. So the pressure is not enough to keep the valve open, and it's going to cause relaxation of the valve and create the sound. The ventricles thus have been emptied. Does anybody have any questions about this? I think it should be pretty straightforward. Okay, yes, you have a question, or yes, it's clear? I hope it's clear. Okay, fantastic. Wonderful. So these are the normal sounds of the heart. What are the abnormal sounds? The abnormal sounds are going to be S3, which is caused by rush of blood into the ventricles. And it can be normal sometimes in tall and thin patients and well-trained athletes. So when we have a lot of blood rushing from the atria into the ventricles very quickly, you'll hear a sound. Okay, some people describe it as a whooshing sound, so on and so forth. And then we have S4, which is caused by blood hitting a thick or non-compliant left ventricle. This is more of a dull sound. The S3 sound is going to be a higher pitch. Now, the S4 sound is always pathologic, okay? S3 can be normal in tall, thin patients and well-trained athletes. These are two high-yield points to remember. I don't think they were mentioned in the lecture, but in previous years, they were always asked about in exams. So, sorry about that. So this is just a phonogram or sonophonogram to kind of summarize everything that we talked about the sounds. During S1 is going to be closure of the mitral and tricuspid, end of diastole, start of systole. S2 is closure of the aortic and the pulmonary valves. So it's going to be the end of systole, start of diastole. You can see here, S1 is at the start of diastole, start of systole, end of diastole, and S2 is the opposite. It's at the latter end of systole and the first or beginning part of diastole. Now, S3 is going to be closer to the start of diastole. Why is that? Because it's caused during the rush of blood into the ventricles. So the blood is still being pushed into and through the atria. S4 is going to be, it's variable, but it's more towards the end of diastole. These are not very important points. It's just for your information. So let's talk about abnormal heart sounds or murmurs. This was such a pain for me back in the day, but I promise it's very simple. All of it is here in this one image. Let's break it down piece by piece. Now, we're not going to talk about the auscultation areas because this is covered more in your anatomy lectures, and there's going to be an excellent class session on that you should totally watch. Okay, so a murmur is any abnormal heart sound. Okay, let's specify that from now. Anytime that a question mentions a murmur, you know that something is going wrong. Okay, now a systolic murmur is going to be an abnormal heart sound heard during systole. Inversely, a diastolic murmur is going to be abnormal during diastole, okay? So stenosis and regurgitation, it's spelled wrong in the slide. Don't look too closely. Stenosis means a rigidity or a stiffness of a valve, sometimes with infective endocarditis, like a bacterial infection of the valves, or with normal calcification with age, like wear and tear. The valves become very hard to move, and that is what we call stenosis. And any valve can become stenosed, but this is more common in the left side of the heart. That's not important. And then we have regurgitation. So the valves normally function to keep the blood moving in one direction. The atrioventricular valves, tricuspid and mitral, prevent blood going back into the atria during systole, and inversely, or likewise, for the pulmonary and aortic valves, they're going to prevent blood from going back into the ventricles after we've pumped it out. We don't want blood going back in the opposite direction. So just make sure that these basic terms are clear in your head. Okay, so let's talk about aortic stenosis. Like we said, stenosis means a rigidity of the valve. So it's going to be a systolic murmur. Why is that? When does the aortic valve open? We mentioned that the aortic valve is going to open during systole, right? Because it's allowing blood to pump out of the ventricle. So the valve opens during systole. We call it a systolic murmur because that's when we hear the abnormal sound, and it leads to a high systolic blood pressure. So why do we hear the sound anyways? You can see here in this image, in aortic valve stenosis or calcification or rigidity of the aortic valve, the valve doesn't open all the way, and it's not really well structured. So the blood, as it is exiting the aortic valve, is going to find it very difficult to leave. Now, also, this is a point to keep in mind, aortic valve stenosis leads to high afterload. Why? Because it's going to oppose the blood leaving the aortic, the left ventricle. This is going to lead to a very high systolic blood pressure. Why is that? Because now the heart has to work extra hard to push open this door that is refusing to be open, okay? This leads to, again, significant afterload. That is aortic stenosis. When do we hear aortic stenosis? During systole, okay? Now let's talk about the other pathology of the aortic valve, which is aortic regurgitation. So like we said, we have stenosis, which is thickening or calcification, and then we have regurgitation, which means that the blood is flowing backwards. Blood flowing back into the heart from the aorta is what we call aortic regurgitation, and it's a diastolic murmur. Why is that? Because during systole, there is so much pressure from the left ventricle that the blood doesn't even want to enter back into it. It's very hard for the blood to move back against a high pressure. But now that the ventricle is relaxed and there is no door keeping the entrance to the ventricle shut, it's going to pour back into the ventricle, right? It's going to trickle back into the ventricle, which is not what we want. We want the blood to move outwards. So that is why we say it's a diastolic murmur that we hear during diastole. It's going to be after the second heart sound. It's not very important for you to know when we hear it, but it's important for you to know the pattern and if it's systolic or diastolic, okay? Now, is the aortic valve pathologies clear to you guys? Is S4 at the same time as atrial contraction? S4 is during diastole, so it almost coincides with atrial contraction. It can be during or after atrial contraction, to answer your question. All right, fantastic. Let's talk about the mitral valve now. So now you should have the basic lowdown. You should have an idea of regurgitation and stenosis. Mitral regurgitation is when the mitral valve refuses to close properly. So it's going to be a systolic murmur. Why? Because the mitral is going to be open during diastole, okay? But during systole, the mitral valve should be closed. Let's go back here. Okay, you see this mitral valve right here? It's going to close during systole, and we want it to remain closed during systole. But if it's open, it's going to allow blood to push from the atria into the ventricles when we do not want it to be that way. So that is why we call it a systolic murmur. Now, sometimes in the question stems, it's described as a high-pitched whooshing sound at the apex of the heart. Now, why apex? Because that is where we can hear the mitral valve the loudest. And then we have mitral stenosis, which is thickening, calcification, or rigidity of the mitral valve. It's going to be a diastolic murmur. Why is that? When should the mitral valve be open? During diastole. So if it's hard to open the valve, if it's hard to open the mitral valve during diastole, we'll hear it during a diastolic contraction, okay? So it raises the pressure in the left atrium. Just like aortic stenosis increases the pressure in the left ventricle, stenosis of this valve, this door right here, will make it harder for the blood to push into the left ventricle, and so the pressure in the left atrium is going to increase, okay? And here is an example. So again, it's a diastolic murmur because that is when we want it to be open. And as a rule of thumb, okay, when the valve is open, okay, when the valve is naturally open, if it's stenosed, that's when we'll hear the murmur. So for example, in aortic stenosis, we want the aortic valve to open during systole. If it's hard to open the door during systole, we'll hear it then. However, regurgitation is going to be the opposite. So the aortic is open in systole. If it's regurgitating, we'll hear it when it's closed. Likewise, mitral stenosis, we'll hear it when it's supposed to be open. Regurgitation, we'll hear it when it's supposed to be closed, okay? So mitral stenosis, this is just a very quick summary, diastolic murmur and raises pressure in the left atrium. Finally, let's talk about patent ductus arteriosus. It's a very scary Latin name, but it's way easier than it looks. So it's a congenital defect, okay? And you might remember this from Dr. Paul's lectures. Here is the ductus arteriosus. Now, it's a connection between the pulmonary artery, which contains non-oxygenated blood, and the aorta, which is oxygenated blood. So what this means is we're moving deoxygenated blood into the rest of the body. That means there's blood that does not contain oxygen, blood that is not fit to sustain life going into the circulation. And that is absolutely not what we want to do. Okay? So normally this exists in the fetus. However, if it's patent, it remains open. This should close by birth. But if it remains open, we'll have the blood moving through. And this, it causes a continuous machine-like whirring or murmur, okay? And the most common complication of patent ductus arteriosus is going to be cyanosis. The baby will appear very blue, and this requires a surgical fixation. Now, you might be asking, why is it neither systolic nor diastolic? Well, that's because this duct is independent of any of the valves, right? It's always going to remain open. So you'll have blood from the aorta going into the pulmonary trunk and the other way around. You'll have blood from the pulmonary artery going into the aorta, okay? It's pan-systolic, pan-diastolic. It's always going to be here, okay? So that does it for all of the abnormal sounds and heart murmurs. I know, it used to seem very scary, but I hope it's clear. Are there any questions about this part of the lecture? Perfect. Fantastic. Thank you, Ryan. So now I want a brave volunteer to answer this question for me. Does anybody want to read? If nobody's going to volunteer, I'll pick somebody by name.
Does it decrease stroke volume?
Decrease stroke volume. Okay. Now, you jumped the gun. I like that. I like confidence. But let's read the question very quickly. A patient is diagnosed with aortic regurgitation. What is the expected change in stroke volume? Okay, before we do that, aortic regurgitation, is it a systolic or diastolic murmur?
Aortic is diastole.
Fantastic, mashallah. Why is it diastolic?
Because you don't want the valve to be open, to be closed. So when the valve is closed, there's gonna be blood flow, a bit like backflow, but
Wonderful, wonderful, wonderful. Fantastic. So you are incorrect, unfortunately. Why is that? Why is aortic regurgitation going to increase the stroke volume? We already explained this in the earlier slides. Can you connect between the things that we talked about? Okay, let's walk through this. Aortic regurgitation, is it going to increase the amount of blood or decrease the amount of blood in the left ventricle?
it increases, so there's gonna be more stroke volume.
Exactly. Why is it more stroke volume? By what mechanism?
Starlink, Frank Starlink.
Exactly. So it's going to increase the preload. This is exactly the same idea in the question prior, except we added a pathology to the equation.
The way I thought about it is there's gonna be more blood flowing backwards, so the normal stroke volume, it won't be as normal because some of that blood is going to flow backwards. So I thought it would
Yeah,
decrease.
that is completely reasonable rationale, honestly. But the pressure produced by the left ventricle is so high that it's going to push the blood out anyways. You feel? Unless the regurgitation is very severe, and then it's going to really decrease the stroke volume. Okay?
Yes, thank you.
All right, fantastic. You guys are doing beautifully. I love how quick you're getting it, mashallah. So here again is just an explanation. When we have blood flowing back into the ventricle, it's going to increase the preload, which increases the stretch, increasing the stroke volume, increasing the cardiac output. Cardiac physiology is so beautiful in the way that it ties anatomy and physiology and everything together. Even though it's very violent, it's all about contractions and pumping. But now is the real deal. Let's combine everything that we have talked about into one big chart. This scary thing. Now, I know how menacing this looks, but let's take it step by step. It's very simple and it's very beautiful, actually. It's very elegant in the way that it combines everything. So first, let's talk about the left ventricle. Let's ignore everything else. The left ventricle, oh, this was animated wrong. Okay, let's look here. Nobody look down here, everybody look up here. The left ventricle, okay, let's compare the volume in the left ventricle as opposed to the time. So during systole, the contraction of the ventricle is going to reduce the volume of blood inside the ventricle, correct? Are we in agreement? I want you guys to open the mics and come on, I want you guys to have it. Okay, yeah, yes, fantastic. Okay, we're all in agreement. I want you to pay close attention because you're gonna see how quickly you understand that big chart. So the left ventricle in contraction will push the blood out, reducing the volume, okay? Now in diastole, in ventricular filling, it's going to increase. Beautiful. So this is the volume as opposed to time. And when we have a decrease, that means it's systolic, right? We have a contraction. And when there's an increase in the left ventricular volume of blood, it's diastolic, okay? Let's talk about the pressure in the left ventricle. This big line right here, this big mountain, okay? During systole, does the pressure increase or decrease? Yalla, guys.
Increase.
Increase. Absolutely correct. So we said multiple times that the left ventricle has to pump a lot of blood into all of the circulation. So it's a very high spike in the pressure. So this coincides with systole. And then this downward curve is going to coincide with diastole, okay, where we have relaxation of the left ventricle. Okay, let's add one more thing about the hada. Now, let's compare these, okay? Here we have the ventricle. When we have contraction, when increased pressure in the left ventricle, is the blood going to decrease or increase inside the left ventricle? Come on, you guys. I'm not going to move on until you answer.
Decrease.
Exactly correct. So because the pressure is pushing the blood out, you'll see a very low dip in the blood. Likewise, when we decrease the pressure of the left ventricle, we increase the volume of blood. Now, I know these terminologies can get tricky, but you got to get used to them so you can pick up on the questions easily. Now, let's talk about left atrial pressure, okay? And it's this orange line right here, okay? Now, Dr. Moni did not focus on this too much, so we're not going to spend too much time on it, okay? But when we have an atrial contraction, naturally, we'll see a bump, right, in the left atrial pressure, okay? Now, the C wave, the way I remembered A wave was A for atrial contraction, okay? Now, the C wave is going to be the ventricular contraction. Why does ventricular contraction raise the pressure inside the atrium? Because everything is interconnected, you guys. So once the ventricle squeezes strongly enough, that's going to put pressure on the atria itself. Think about the anatomy of it all. It's going to squeeze the atria, thus increasing, right? We see a little bump here, a very quick bump in the atrial pressure, okay? And then finally, this slow increase in atrial pressure is going to be the V wave, or the end of ventricular contraction. End of ventricular contraction is code for diastole, okay? In diastole, we slowly increase the amount of blood inside the atrium, which slowly increases the left atrial pressure, okay? Is this clear to everybody, the left atrial pressure? I walked into my CVP final not understanding this concept, although it's, ridiculously simple. Wonderful, okay. So now let's bring it all together. I'm not going to talk about the electrocardiogram, okay? Because this is going to be covered in another lecture, but you should, have some idea of PQRST. Does somebody want to, talk about this a little bit? Do you want to tell us, does anybody have a basic idea of what the cardiac cycle is like? Okay, you know what? I'm just going to explain. So the cardiac cycle is basically an explanation of the entire heartbeat, okay? The entire cycle motion of the heart through time. Now, it's going to go through systole and diastole, so on and so forth. Now, during systole, we have a very high jump in the left ventricular pressure, okay? And in diastole, it's going to be reduced, okay? So that's the first thing that you should do. Between these two big mountains of left ventricular pressure, we have the caverns, the canyons of diastole, okay? Let's divide it into thirds. Diastole, we can split into 3 parts, okay? The first third is the opening of it's going to be the opening of the atrioventricular valves, the mitral and the pulmonary, okay? Now, why do they open? It's because the pressure from the contraction of the left ventricle is gone now, and it allows for the valves to open, right? There's no longer the pressure from the opposite end preventing their closure, their opening, sorry. And this is what we call rapid filling, okay? And you can see here, the V wave is going to go down. Remember what we said about the V wave? It's the end of ventricular contraction. So this is the blood inside the atria increasing. Once we open the atrioventricular valves, the V wave will dip. The atrial pressure will reduce. And that's why here, this dotted line, we see a reduction, okay? So that is the first third of diastole. The second third, this in green, is the continuous filling, okay? The slow filling. Why do we call it slow filling? Because we still have not contracted the ventricles, okay? The pressure is low, and that keeps the AV valves open, okay? The mitral and pulmonary valves. So blood is slowly going to move directly. Hold on. Yeah. It's going to move directly from the veins into the ventricle. So through the atria into the ventricle, okay? Because this remains open. The mitral valve remains open because this is not contracting, okay? So that is the slow filling stage, the second third, okay? And then finally, we have the final third of diastole, which is atrial contraction. Now here, we have the last 20%, give or take, of the blood inside the atria filling into the ventricle. And that coincides with the A wave, which we said was atrial contraction. And this is before systole starts, okay? This is the diastolic stage of the cardiac cycle. Very simple, very beautiful. Now, if you're looking at the ventricular volume down here, you can see why we call them fast and slow, okay? The ventricular volume, is going to increase very quickly in the first third, okay? It's going to increase slowly in the second third, and then in the final third of atrial contraction of diastole, you'll see a small bump. This is the remainder of the blood being pushed out. Wonderful. Now, let's talk about the systolic thirds, or the systolic section of the cardiac cycle. First is going to be isovolumetric contraction. Such a big word, so scary. Why do you have to make it so complicated? The ventricles here are going to squeeze, okay? There's a very high pressure. As you can see, this big spike in the pressure within the left ventricle, right? We can see it here. However, if we look at the left ventricular volume, it's not changing. Why is that? Because the aortic and pulmonary valves are very arrogant. They require a lot of pressure to be pushed open. And that's why we call it isovolumetric contraction. The volume it remains the same, hence iso, right? Iso, same volume contraction. The pressure is not enough to open the valve, therefore, the volume is not going to change, okay? And that is the first third of the systolic stage of the cardiac cycle. The second third is ventricular ejection. Now, a jet of blood is going to be flying through the aortic and pulmonary valves because the pressure was finally enough for it to open, okay? This one, very simple. And you see a fat dip, this big slope, this big slide in the ventricular volume. That is when most of the blood is being ejected, okay? Finally, we have isovolumetric relaxation. This is the same idea as isovolumetric contraction, just opposed, okay? It's the flip end. It's the flip side of the same coin. Here, the pressure is so high that the valve remains open for some time, okay? Even though the left ventricle is not, in the process of contraction. So the ventricle is now relaxed. However, because of the vast amounts of pressure that it has produced, the valve remains open, okay? And that allows some blood to flow into the ventricle, okay? Now here, the aortic valve, even though Dr. Moni did not touch upon this, this is a very nice way to tie things together, to tie together the systolic stage of the cardiac cycle. Here we see in this dotted line, okay, this is the aortic valve. Is it open? Is it closed? In isovolumetric contraction, the valve is not open yet, okay, because it has not reached the threshold pressure. When it reaches the threshold pressure, which is about 80 millimeters mercury, it then shoots open, okay? And as you can see here, again, in isovolumetric relaxation, the valve remains open. You see this little bump, right here? The valve remains open for some time until the pressure drops down fast or far enough for it to close, which marks the end of isovolumetric relaxation. That is the entire cardiac cycle lecture in a few slides, okay? You guys now have like the foundation. We talked about the foundation. We talked about the pressure, preload, afterload. Does all of this make sense? Do we have any questions? Okay, what does the pulmonary valve have to do with this? Let's answer the first question. So the pulmonary valve is not measured here, okay? But the idea is the same, that we need pressure to open the pulmonary valve. It's much lower. It's not present in the cardiac cycle. So honestly, you can just ignore it. The pulmonary valve doesn't have anything to do with this chart specifically, but it's the same concept, okay? Let's see another question. In the isovolumic periods, both valves should be closed. Okay, so you are correct in that the isovolumetric contraction, the valve remains closed, okay? And even in the isovolumetric relaxation, we also have closure of the valve, although sometimes it can be slow, okay? It's going to close during the isovolumetric relaxation, but in the slides, it's mentioned that the valve remains open for a small time. Now, why do we know that it closed? Because it coincides with the S2 sound, right? The closure of the aortic and pulmonary valves, right? So when they closed during the isovolumic relaxation, then we have production of the hub. So to summarize, isovolumic contraction, closure of atrioventricular valves. Isovolumic relaxation, closure of the AV valve, the aortic and pulmonary valves. Sorry if I'm getting it mixed up, okay? Which is also why it doesn't change, right? Since the blood isn't going anywhere. Exactly correct. Exactly correct. Because they are closed, the blood pressure does, or the blood volume does not change. Okay. That it was written in the slide for diastole. Okay. Let's go to the slide for diastole. Here. The first third opening of the AV mitral and pulmonary valves. It's just to help you remember that the you're correct. Yeah, the pulmonary valve has nothing to do with it. That is a mistake in the slides. I will correct that and inshallah send the corrected version back to you. Thank you so much for pointing that out. That's a mistake on my end. Okay. So that is the cardiac cycle in the systolic stage. The last part of our PAL session is going to be the pressure versus volume loops. We're going to take a 10-minute break, and then inshallah, we'll finish out everything. We'll talk about PV loops. It's not going to be as long as everything we talked about. We're going to solve a few questions together, and then we'll be on our way, okay? So this shouldn't take, all right, yeah, this shouldn't take too long at all. Let me share my screen. All right, let's go. So pressure versus volume. This is going to be the culmination of everything that we have talked about so far. And we'll break it down step by step so it's super easy to remember and understand. So to get started, pressure against volume. First, we're going to look at the what we call the pressure versus volume loop. Now remember, the left ventricular pressure is going to be a very high peak, right, in the cardiac cycle, as opposed to the left ventricular volume of blood, which is going to be a dip and then a bump, right, as according to the pressure. Let's put the left ventricular pressure on the y-axis and the volume on the x-axis. This is a typo, ignore it, okay? Now, when does blood pressure spike, right? It spikes during systole, right? With this big jump here, if we look at the pressure on the y-axis, this big jump right here, is going to it's going to coincide with this part of the cardiac cycle, right? And here, when it dips, it's going to go down. The pressure is going to go down at the end of diastole, okay? So diastole is going to be this line right here where pressure, ignore volume, where pressure goes all the way down, okay? And then systole is going to be this line where pressure goes all the way up, okay? Okay, now moving on, we can then split this chart into systole and diastole. Here, where this part, where the pressure is going very high, okay, and remaining high, this is systole. And then here, where the pressure drops, this is going to be diastole. Now let's look at the volume of blood, okay? This on the x-axis is going to be the volume. During diastole, the volume is going to increase. Isn't that correct? So we see that the line goes to the right. Now during systole, the volume is going to decrease. It's going to go to the left, right? It's going to go to the left. So the volume of the blood is going to get reduced. It's going to get pushed out of the heart. Therefore, we can say that this part of the graph is diastole, where we have a reduction in pressure and increase in volume. And then this part is systole, where we have an increase in pressure, right? And a reduction in volume. Now, let's look at when the valves open and close. Now, just a disclaimer, these are slides from Boards and Beyond, which I think did a great job of breaking down the PV loops. Strongly recommend that you go through Boards and Beyond. Excellent resource, okay? Now, we know that the mitral valve is going to open after isovolemic contraction, right? At the ejection phase, right here, okay? So let's go to our loop here. The mitral valve is going to, the aortic valve. The aortic valve is going to open during the ejection phase when the pressure is super high. So here, when the pressure, the left ventricular pressure is at its highest is when the aortic valve opens. What does this coincide with? This is going to coincide with the ejection phase. Here, the pressure is so high, but the aortic valve has not opened, so the volume remains the same. This line, thus, is the isovolemic contraction. Once I reach a high enough pressure, the aortic valve is going to open, and the blood volume is going to escape the heart. So the chart will go to the left. The volume will decrease. Once the contraction is over, I will reach a point where the relaxation, the pressure gets low enough so that the aortic valve closes. What happens when the aortic valve closes and the contraction ends? The volume, the pressure will go all the way down, right? So this is going to coincide with the start of diastole, okay? This is end of systole, start of diastole. Now let's go down through here. The dip in blood pressure, this is going to be equal to diastole. This is the quick filling phase of the cardiac cycle, okay? And then we'll have an increase in volume during diastole where the pressure of the left ventricle does not change, okay? The stroke volume, thus, is going to be equal to the width. Remember, what is the x-axis equal to? It's going to be equal to the volume of blood. The y-axis is the pressure of blood, always the pressure of the left ventricle. Keep that in mind, okay? So the stroke volume is going to be this point right here. This point is going to be the end diastolic volume. Why is that? Because this is the maximum amount of blood that we got before the pressure went all the way up. We said that the pressure goes all the way up during the start of systole. So this point is the end diastolic volume, okay? And then here is going to be the end systolic volume right here. This is the end systolic volume. Why is it the end systolic? Because this is the end of contraction. All of the blood has been pushed out, and the aortic valve is going to close at this point. A stands for aortic, M stands for mitral. Disclaimer, this is only for the left heart, okay? So the difference between those two, the width of this pressure volume loop is going to be the stroke volume of the heart. You see how it ties everything together? Now let's talk about preload and afterload. Why is this point right here equal to the preload, and why is this one equal to the afterload? So the afterload is going to be the highest point of pressure where the aortic valve opens. Remember, afterload is against the flow of blood. Preload is going to be the maximum stretch of the myocytes, how much blood we're filling. So the end diastolic volume and the end of diastole, the start of systole, all coincide with this point right here, where it is the maximum preload, the maximum end diastolic volume. Let's bring it all together. Let's tie everything together, okay? At point A, right here, we have the end systolic volume. Why is that? Because the aortic valve has closed, okay? The mitral valve is going to open because there is no longer the pressure from the left ventricle keeping it closed. Wonderful. Now let's move here with diastole. The volume is going to increase. So we're going to go to the right, to the right, to the right until we reach the end diastolic volume, which is equal to the preload, okay? Once we reach the end diastolic volume and we start the ventricular contraction, the mitral valve will close naturally. Now, here is the end diastolic volume and the start of systole. Why is the volume not changing? Because remember, at the beginning of systole, we have isovolumetric contraction. The valve, the aortic valve, has not reached a sufficient pressure to open. So we have this upshoot in pressure, this straight line, where the aortic valve has not opened. Once it opens, we start the third part of our pressure volume loop, where the aortic valve opens and we have ejection. Now, in ejection, you see that all the blood that I filled is getting emptied out, right? The left ventricular volume is getting reduced. We keep doing that until the left ventricle stops contraction and the pressure drops down enough for the aortic valve to close, okay? Once the aortic valve closes, we have point D, and that is when we start the isovolumetric relaxation, okay? And then we keep going ad infinitum. This is the pressure volume loop. It ties everything in beautifully, and it summarizes the entirety, basically, of everything that we have done. Now, one last point, okay? How does preload and afterload affect the pressure volume loop? So this is the normal pressure volume loop. Afterload is going to increase the spike. Can anybody tell me why it's going to increase this spike of left ventricular pressure? Does anybody want to try?
Can I try?
Yeah, go ahead.
Because it's gonna like require more like energy or more effort, like Rayan said. Yeah, it's gonna increase the amount of, it's gonna raise the pressure cap that afterload is.
Exactly. Fantastic. You're absolutely correct. So it's going to make it harder for the aortic valve to open. Thus, the line is going to be way higher, right? We have to reach a way higher pressure for the aortic valve to open. Now let's see what happens when we reduce afterload. If it's easier for the valve to open, we'll have a lower line. Isn't that correct? So it's easier to push the aortic valve open. Thus, the left ventricular pressure will reach a lower peak, okay? Now we have this line, the end systolic pressure volume relationship, the contractility. The more diagonal, the steeper the slope, the higher the contractility. This is raised in sympathetic stimulation in states of hypernatremia or excessive sodium in blood and things akin to that, or during exercise. This here is going to be the preload. Now, if you recall, the end diastolic volume indicates the preload, right? It dictates what the preload is. So this line right here, the more blood I put in, the higher the stretch. So if it's over here, that means I have higher preload and a higher end diastolic volume. If it's here, if this point is more to the left at a lower volume, that means the preload is less. There's less stretch on the heart, thus leading to a lower preload. Does anybody have any questions? Yes, exactly right. No, because it will require more pressure and thus it'll be harder to have. Does anybody have any questions about the pressure volume loops? Is everything clear? Okay, what happens when we change contractility? When we change contractility, we're going to be pushing more blood out of the heart at a slower time. So here, you see the contractility. We're going to have a steeper slope, okay? Meaning that the volume will change with less change in pressure because contractility is the strength of contraction. If this contraction is stronger, The pressure needs to be less to push the same amount of volume because we're just pushing so much. Is that clear? All right. So the lectures covered in this session, you can find them on the first slide of this PAL session. Thank you guys so much for your time. I know this session dragged on a bit, but this is my contact information. If you have any questions, this is my phone number. Feel free to reach out. Now, here will be a feedback form and a quiz. Okay, the quiz will have questions about everything that we covered in the session. And I urge you to give feedback. How can I better improve? What things did I do right? What things did I do wrong? Thank you guys so much for your time and have a wonderful day. Allah ya'tikum al-afiyah jami'an. All the best.